Yep.
Great. Well, on behalf of my co-host Dr. Bettina Hubner, and myself, welcome everybody. I'm John Kelly, co-investigator on the project with Dr. Hubner. You can see here, this is our steering committee for this NIDA-funded initiative to expand the research infrastructure for recovery support centers. Next slide. And we have been doing a number of things, including this webinar series, of course. Thank you for coming back. And for those of you who are new, welcome. One of the things that we have also started to do, thanks to largely to Dr. Hubner's efforts, is to create a new recovery center survey, which you can see here on the right. We've got our measure of success. This is meant to be motivating. So if you're out there and you haven't filled out the survey yet, please do so. And you can see the link at the bottom here to email. If you haven't gotten the survey, please send us an email so we can send it to you, because we want to obviously get as many recovery support centers around the country as we possibly can, so we get an accurate picture of what's going on in the recovery support centers, and also get your feedback about what the best measures are for measuring impact of these centers. So thank you for that. As we always do, we have a spotlight feature of a recovery support center. And today, actually, yeah, just before I mention that, go back there, Hazel. This is our next seminar is coming up. This gives you this is a fantastic graphic, thanks to Hazel Simpson here, who's put this together. But you can see coming up over the next several months, you can see that the seminar topics, medication-assisted treatment in November, and then we'll be featuring some of our pilot studies, funded studies through our grant. Then we'll be focusing in January on rural community centers, and then in February on telerecovery and mHealth, which should be very exciting. So thanks, Hazel. And then, as I mentioned, the spotlight feature for today is on anchor recovery, right down the road here in Rhode Island. So I'll turn it over to Michelle Harder. Is she here, Michelle?
I don't know if Michelle is here yet, or she might be here under a different name, but Michelle, if you are here right now, you can go ahead and speak. And if not, I guess we can cycle on to the next sections and maybe circle back when Michelle gets here.
Yep.
Sounds good, sounds good. So Michelle, if you get here, let us know, we'll come back to you. As you know, we always kind of keep track of who's here, because our goal is really to bring together multiple stakeholder groups around recovery community centers. So we want to make sure that we actually do reach multiple groups. So if you guys can complete our Zoom poll so that we can keep track, that'd be great. And on our website, actually, we will put a pie chart. We've pulled together who's been at the past events, the past 9 seminars, and Hazel and I will be updating that later on, so you guys can see that on our website. But we so far have been great in reaching our multiple stakeholder groups. Let me just quickly complete this myself.
And the poll should be up on everyone's screen, and you need to scroll down and complete all the questions to be able to submit your answers.
And then we also included a true or false kind of quiz at the end, if you could complete that as well. And this will be previewing some of the things we'll be talking about in today's seminar. How are we doing on poll completion, Hazel?
We have about 50% completion right now, so maybe we can give it a few more seconds.
Are you actually able to advance slides while we still keep the poll open?
Yeah.
Perfect. So while you're still completing the survey, I want to introduce our speakers. We are going to be just going in this order right here. We will have Dr. Monica Skewes presenting from Montana State University, who's just going to talk about some of the points that you just read about in our poll. And then Mr. David Withers is a founding member of AFRO, which will be telling you more about. He'll be coming right after, followed by Ms. Laurie Johnson, who is a co-founder of AFRO as well as leader of Dreams Awakening and RCO. And they will really be talking about their perspectives on some of the points that Monica has raised and really speaking to the Recovery Community Center experience on these targeted questions. As John was mentioning earlier, our next seminar, which we'll be briefly touching upon today, will focus on medications for opioid use disorder. And if you are director of an RCC and you would like to present here, please email us, let us know so you can be incorporated into our next seminar. How are we doing on the poll, Hazel?
We have 80% now, so I think I'll end the poll and share the results, if that's good.
Wonderful. All right, if you want to go down to the bottom, I think it's going to be important for Monica to see where people fall on the true-false items. And Lawrence, I think if you click again on the closed caption button on the bottom bar of your Zoom, you should be able to select an option that says hide subtitles. And Hazel, are you able to scroll down on the view? Oh no, everybody does it themselves. You don't do it for everybody. Perfect. All right, then without further ado, Monica, if you could introduce yourself and take it away from here, you kind of see what perceptions are around some of these issues you'll be talking about.
Sure. Hi, Monica Skewes. I'm the Associate Professor of Psychology at Montana State University, and I engage in community-based participatory research with American Indian communities around addiction and recovery. I'll be talking about harm reduction. I'm going to give a really brief overview of systemic racism in drug laws and addiction treatment, a couple different examples of compassionate care and harm reduction approaches, and then benefits and limitations of harm reduction for improving health equity. Next slide. So, drug laws and racism. In 1980, drug offenders comprised 6% of prison populations, and currently about half of federal inmates are incarcerated for drug offenses. The majority of these people are people of color, and the majority of the offenses are simple possession. It's important to note that drug laws in the United States were not developed with public health in mind. They were developed within a context of racism and xenophobia. It has really nothing to do with the dangers of specific chemicals, but more about the population that was using them. For example, there were fears of Chinese immigrants using opium and Mexican immigrants using cannabis and cocaine being used in Black communities. So this really motivated a lot of our current drug laws. Next slide. And these drug laws persist. It's true that most users of illegal drugs are white. The most drugs being used are by white people, but people of color represent the vast majority of arrests and convictions. The risk of incarceration is 7 times greater for Black than white people who use drugs once a month or more. And people of color also receive harsher penalties and longer sentences when convicted. One kind of striking example of racist drug policies is the Anti-Drug Abuse Act in 1986 that created a 100-to-1 sentencing disparity for crack versus powder cocaine. And this policy really affected primarily Black Americans. In 2010, President Obama changed this to an 18-to-1 sentencing disparity from crack to powder cocaine. But this really doesn't make sense. These are 2 different forms of the same chemical. So it's still quite illogical and really does affect Black communities more than anyone else. Next slide. There's an incredible amount of evidence of systemic racism and substance use disorder treatment as well. Black and Latinx Americans are less likely than white people to receive specialized addiction treatment at all. In a recent national survey of drug use and health, Black Americans had the highest rates of opioid-related overdose deaths. This was in 2019. And it's increasing in Black and American Indian Alaska Native communities, overdose deaths from opioids. Along with that, Black patients with opioid use disorder are less likely to be prescribed buprenorphine and more likely to be prescribed methadone, which is much more burdensome and it's also more stigmatized. In addition to that, many Black patients avoid seeking treatment at all out of fear of punitive responses and moral judgments. And there's a really major lack of culturally grounded, culturally resonant interventions for all ethnic minority groups in the country. Next slide. So one approach, other than a criminal justice approach, to help the addiction problem in our country is compassionate care and harm reduction. This is a pragmatic public health approach that's rooted in compassion. It views addiction as a health problem and not as a moral failing or a criminal problem. It involves a variety of strategies to reduce harm associated with addictive behaviors. And as examples, we'll be talking about non-abstinence recovery goals, medications for substance use disorders, safe injection sites, and housing first models that all have an incredible amount of evidence for their advocacy. Next slide. So regarding non-abstinence recovery goals, research suggests that patients are more likely to achieve goals they set themselves compared to goals set for them by other people. Also, when people start addiction treatment, a lot of times they're not really ready for complete abstinence or they don't think that's possible for them. So harm reduction is a way to minimize these consequences and move people along these stages of readiness to change. Small successes build self-efficacy and increase motivation. Recent research has shown that, in the absence of abstinence, reductions in substance use are clinically meaningful and align with patients' goals more strongly than abstinence. Another study found that any reduction in World Health Organization risk drinking level during treatment was associated with meaningful improvements in alcohol consequences and mental health outcomes up to 1 year post-treatment. So it's not the case that complete abstinence is the only way to improve health. Any reduction in drinking is helpful for health. Next slide. As many of you know, there are a number of medications for substance use disorders. There are FDA-approved drugs that effectively treat nicotine, alcohol, and opioid dependence. Research shows that longer treatment with buprenorphine, so 15 months or longer, is associated with reductions in inpatient and emergency medical care, opioid-related hospital use, opioid overdoses, and prescription opioid use. So a lot of folks support buprenorphine as a short-term treatment with a rapid detox, but longer-term treatment has better outcomes. Medications for opioid use disorder is the gold standard of care, but not all patients have equal access. White, insured, or private pay patients are more likely to receive buprenorphine. Another study found that 35 white patients received a buprenorphine prescription for every patient of color. So not everybody has equal access to this gold standard of care. Next slide. Another harm reduction strategy that has incredible evidence is safer injection facilities. This is a photo from one in Vancouver, British Columbia. Safer injection facilities provide all of the services of needle exchange programs, but they also provide a safe, clean environment in which to use injection drugs. People who use drugs will bring their own to these places, and they will be supervised as they use in a safe and clean way. There are medical staff on site who monitor and treat people for overdose. They also offer basic medical care, education, and referrals to treatment. Participants who use these sites also will explain that it's like the only encounter they have with a healthcare provider that treats them like a human being. That is, it's an incredibly like rewarding experience on many different levels, and it helps people stay safe. There are still overdoses, but there aren't overdose deaths because people are on staff with Narcan. There's overwhelming evidence for safer injection facilities for preventing disease transmission, overdose deaths, and increasing treatment engagement. So folks who go to these centers are more likely to end up going to treatment. Next slide. The other model we'll talk about is called Housing First. Housing First is designed to address unstable housing among people with substance use disorders and severe mental illness or other psychiatric disorders by essentially moving them into their own apartments. It's a way to give people a place to live, a safe place, as an alternative to shelters or transitional housing. When people have housing instability, they often end up, if not on the street, in jails or in ERs, which are incredibly more expensive than just an apartment. Interesting approach to Housing First is that it does not require abstinence, and it doesn't require people to get treatment in order to have an apartment. I think an old way of looking at this, old models were like, people need to have their mental health addressed, or they need to be sober from alcohol and drugs in order to handle having an apartment. And it turns out research shows that that's not actually the case. Housing is a basic human right. Not having housing is incredibly stressful, and stress contributes to relapse for both substance use disorders and other psychiatric disorders. So it's not the case that people who are not, who are using substances at all or who have mental health problems need to treat those before they can handle having a house. So in research studies with Housing First, participants did remain stably housed over time. They did not have increased substance use, and they didn't have increased psychiatric symptoms. So those things stayed stable, but their safety and their quality of life improved. In Seattle, Housing First saved taxpayers more than $4 million during the first year of operation alone. Like I said, if people aren't stably housed, they are a lot of times in jails or in emergency rooms, and these are incredibly expensive. Participants also in Seattle had significant decreases in drinking compared to a waitlist control group. So Housing First has a lot of great evidence for it. Next slide. In terms of harm reduction and how it aligns with anti-racism, harm reduction encompasses any measure to reduce the harm associated with substance use. Any step toward a healthier life is the step worth taking. It provides opportunities to promote health among stigmatized populations, and stigma is a huge contributor to both addiction and relapse mental health problems. Harm reduction is focused on meeting people where they're at with non-judgmental support, understanding, and compassion. And it provides opportunities to shift policy and practice in a way that emphasizes social factors and inequities. Next slide. So I would argue that harm reduction approaches are absolutely necessary and valuable, but aren't sufficient. There is a larger systemic problem that we need to deal with. There remains a crucial need to address systemic racism and oppression that's at the root of substance use disparities within a social justice framework. We still have unjust drug policies. We still have racism in criminal justice and healthcare systems that needs to be addressed. There are inequities in the social determinants of health. Your zip code determines your life expectancy, and this needs to be addressed. There's unequal access to effective treatments, and there are insufficient opportunities for culturally grounded treatments that work for everybody in this country. So we have a lot of work to do, but harm reduction can definitely be part of the solution. Next slide. think that's it.
Thank you, Monica. That was really helpful and great. And for those of you who were seeing some of these facts, if you want the papers underlying them, email us. We'll be happy to get you all those resources and connect you with what else we have available. And of course, the recording of this seminar and the slides are also going to be available later on. All right, David.
Hey, everybody. I'll move quickly. I thought I was sharing this. I was going to share this on my own, but I can't get it to.
So I can see your slides, just not in
Oh, you
presentation
can't?
mode.
Because I can't see them. You can see my slides.
Would you like Hazel to screen share?
Yeah, please. Thanks.
Mm-hmm.
Hey, good afternoon, everyone. My name is David. I'm a person in long-term recovery. I like to say that part first. And all I'm getting is a black screen. So give me 1 second.
Can everyone else see the slide?
I can see. What about the rest of you all? See some nodding.
I can see it.
Yes.
Thank you.
Yes.
I'm David. I'm a person in long-term recovery. Thanks, Hazel. And I just like to say that first. As a result of my recovery, my particular pathway started in 1984. I've been able to sustain myself in recovery for more than 37 years. I have a GED as a result of my recovery. I never graduated from high school as a result of my active addiction. I have a master's degree in social work from the #1 school of social work in America. And I have a PhD in social work from a Research One institution. I just like to share those things in case there's someone out there who's like thinking about all the many things that they can accomplish as a result of their recovery. If education is one of them, I'm living proof that you can do it because I am not that smart. And if you don't believe me, you can just ask my friends. I am a founding member of Afro. If you go to the next slide, I'll tell you a little bit about who we are. There are 23 of us. We're subject matter experts on all things specific to recovery support services in the African American community. We have more than 300 years of sustained recovery, which is a lot of time. We have more than 200 years experience, not just working in Black communities, but living in Black communities. We believe that's important. We believe that we know better than anybody else what's best for our community. Now we have folks who come from outside of our communities who pretend that they know more than we do about what's best for us, but they're bogus, they're not real. We not only work in our communities, but we live there too. Some of us have been around since the early 2000s. There's a few of us who started providing recovery support services in the late 1990s. The program that I founded in Atlanta was founded in June of 1999. I know that there are others that have been around since that time as well. Our goal is simple. It ain't complicated. We hope to raise the funds, and we were hoping that these funds would come from our federal government that will provide us an opportunity to provide training and technical assistance to groups in African American communities, resulting in at least 40 new African American peer-led recovery community organizations in our nation's largest African American communities. And I'll tell you why that's our goal in a minute. Next slide, please. Look, can you just go to the next slide? Because I want to show you something. Now, this is supposedly from our current administration. I say supposedly because I don't know if you read this. I don't even know if they wrote this. I just know that it's out there. So I'm just going to respond to it. And I'm going to ask you to do two things this slide. I'm going to ask you to listen to me and kind of read it along at the same time. This is a position from the current administration. It says there's a clear and discernible need to take steps to advance racial equity issues resulting from current drug policy. President Biden has emphasized the need to eradicate racial inequities. I mean, did this guy just discover this like since January this year? Black people have been knowing this for I don't know how many years in the criminal justice system, and has stated that people should not be incarcerated for drug use, but should be offered treatment instead. Does that mean that all of the Black people who are incarcerated in our many state prisons who are there because they met a DSM-5 criteria for one of the substance use disorders at the time of their arrest, are they going to be released? If not, then you could have kept this to yourself. I want to just talk a little bit about the second paragraph, the parts that's highlighted. Directs agencies to pursue comprehensive approach to advance equity for all. Now, you should be able to stop there with that sentence, including people of color, as if we're not part of the all. And if you just go down a little further, it says, for many people with substance use disorder, access to care in the United States is inadequate. I'm not for sure if they're looking for a pat on their back. We've known that substance use treatment for Black people has been inadequate for as long as I've been alive. But for BIPOC, the situation is worse. I mean, did he have to research this to figure this out? He could have just called Afro. We could have told him this. A recent study shows that Black individuals generally enter addiction treatment 4 to 5 years later. I highlight this because, let me just go to the next sentence, the last sentence, I'll tell you why. This discrepancy in treatment access is important to address at a time when rates of overdosing are increasing for some communities of color. My dissertation focused on Black recovery support services. I can assure you all my research said that that gap between the time when Black people and white people access treatment was more like 8 to 12 years. Next slide, please. Look, this ain't complicated. Afro ain't complicated. All we want is for our federal government to do for Black folk what you did for white people. This is what you did for white people. When white people started dying from opioids, you created all these awesome services that have resulted in a decrease in the number of white people who are now overdosing from opioids. At the same time, however, guess what's happening? There's been an increase in the number of Black people who've been dying. So this focus on white people has resulted in a neglect and abuse of Black people. So all we want you to do is do for us what you did for white people. Take away those resources from white people, give it to Black people. That's what equity means. It doesn't mean anything else. So you can't make the claim that you believe in that in this little report that you put out, but you don't act on it. Next slide, please. Look, I'm not going to stay on the slide too long. How has racism impacted my personal recovery? I had to think about this. You know, I felt like in the beginning of my recovery 37 years ago, I started my recovery in Atlanta 37 years ago before gentrification. Atlanta was 99.9% Black. Everybody in my pathway was white. So I felt a bit marginalized and had trouble with that. But the funny thing about that experience is that those white people were loving and caring, and it was because of them that I'm here today. I ain't confused about that. As it relates to my community, it changes a little bit. When you drive through my community, you see on every single corner a liquor store. In every other corner, open air spaces where they're selling drugs in the community like it's a flea market. You can drive through my community and people will stop you on the street and ask you, do you want to buy some crack? Or actually, do you want to buy some other kind of drugs? We have issues with that. And the reason why we have issues with that is because you can't do that in Buckhead. Buckhead ain't that far from where I live, except that it's all affluent. But you can't drive through Buckhead and see no liquor stores on the corner, nor can you see people standing out on the middle streets of Buckhead talking about, I got this, I got that. So Black people abused by substances are more likely to end up in prison. Professor Monica did an excellent job on that. Let's go to the next slide. This is one of my favorite photos. I mean, this is it. When Black people use substances, we criminalize it. We send us to the penitentiary. When white people use substances, we send them to the hospital. I mean, it can't get no more clear than that. And I ain't making this up. Even the folks at SAMHSA know that. Did anybody get upset at Professor Monica's slides that had all those data quotes from SAMHSA? It's almost like SAMHSA says on one hand, Black folks are catching hell, but on the second hand, they don't do nothing. You would think right after that, they would say, this is what we're going to do. We're going to do for Black folk the same thing that we did for white people. But that's not the case. Next slide, please. What is our stance? I need to preface this with, my opinion doesn't necessarily reflect that of Afros. Some of my colleagues in Afro, they call me unpredictable. They say, Dave, we don't know what you gonna say. You know, we just sit in our seats and we grit our teeth and we hold our chairs real tight because we don't know what you gonna come out, what you gonna say. One of my colleagues in a conversation with me shortly after the presentation a week or so ago that I did for the congregational thing, she said that not only did I look like Malcolm, you notice I don't have my wide rim glasses on today. My glasses that make me look like Malcolm, brother Malcolm. She said, you were sounding like Malcolm X. I got excited. I thought that was a good thing. She said, David, you don't want to sound like Malcolm or look like Malcolm when you're talking to politicians. That's just not a good look. So I put on my different glasses today. But we support multiple pathways to recovery, but our pathways in our community are slightly different than those pathways that are promoted in the white community. You cannot have recovery support services in the Black community and not have a partnership with the Black church. It ain't possible. The Black church is the leader provider of support services in our community, have been for more than 400, 500 years. They were the providers of trauma-informed care for folks who were hanged, for the friends and families of the Black people who were lynched. You remember, this wasn't that long ago. My mother was alive when lynching was going on. She was born during the time when lynching was still happening. And I got friends who say, David, there's lynching that happened a couple months ago. So they were the ones providing trauma-informed care to families back in those days. You have to have a partnership with them. We have injection sites in our community. We have not injection sites, but we have syringe exchange programs in our community. We're supporters of medication-assisted treatment. We believe in supportive housing, but we believe in both housing first and abstinence-based models. They both are important, have an important role in our community. Neither one is more important than the other. But you also have to have recovery coaches able to provide education to the Black folks in our communities, the mamas and the daddies and the uncles and aunties who don't understand syringe exchange, who don't understand housing first, because there are a lot of them. And we have to have that in our community. So you just can't come to our community and say you'll open something up without talking to the elders in our community. Next. I'm gonna try to speed this up, because next slide, please. I had to throw this in there because this is research from one of my heroes, John Kelly. And I support this and we understand this, but again, in our community, John, even though there's a bunch of people in our community who are recovering in pathways other than 12-step recovery, we have to be able to educate the elders in our community because they believe in abstinence-only approaches, many of them. The elders in our community, like, if you still drinking and you tell me you're in recovery, I got issue with that. If you switch from shooting heroin to smoking heroin as a harm reduction pathway, we don't understand that. So even though there are millions of folks in our communities all across the country recovering in different pathways, we have to have communication with elders in our community so they can understand those different pathways. Next. Yeah, we anti-racism, but you know what? I'm an expert on racism. I've studied it. I've been a victim of it for over 60 years. I know what it means, and you have to have a component. It's just, I know what I'm looking for in order for racism to be there. It just can't be like one person who's prejudiced against another person. It has to have the power dynamic. You have to have an ability to prevent someone from accessing something because you have a power that they don't have. And if you're absent of that power, I wouldn't call it racism. I would call it something different. But Afro was formed to challenge racist barriers. That's what we do. We believe that the fact that since 2004, there's been an incessant increase in the number of Black people who have accessed treatment through SAMHSA funding programs. We think something's wrong with that. Not an increase, but a decrease. That's not the case for white people. It's been an increase, albeit slight, but an increase nevertheless. And plus, they started out way ahead of us. They got this many treatment. We got this many treatment. We seeing our slots going down. We seeing theirs increasing. Something is wrong with that. I mean, just tell me to my face the Black people don't matter. The Black lives don't matter. Then I'll understand. Don't pretend like I do. But your data says something different. Your data says you care about white people because you provide service for them, but your data don't say that about Black people. So let's go to the next slide. Look, we want to partner with researchers in our community. We really do want, we're excited about community-based research methods, just like Professor Monica mentioned earlier. We want those in our community. We want to develop recovery support services that are specific to Black people and work extremely well for Black people. We want clinicians to understand that we're not their competition. Our recovery movement is not competition. We can augment each other. We're both equally important. And you'll hear that a lot in recovery talks or recovery support services conferences, or you hear favors say that kind of stuff. But I'm gonna tell you something, the salaries don't suggest that we're equal. We claim that recovery coaches and clinicians are the same and both have invaluable roles, but the salaries say something different. I remember I grew up in Pontiac, Michigan. I'm old enough to remember when women who worked at the General Motors plants made less money than the men for the simple fact that they were women, not because they weren't as good, because many of them or most of them were. So if you're going to say that recovery coaches are just as important as clinicians, then pay us at the same degree that you pay clinicians. And lastly, we love that healthcare providers are recognizing the value of recovery coaches. We want to get excited about that. I love what CCAR is doing in Connecticut, placing recovery coaches in Department of Corrections and prisons and jails and hospitals and emergency rooms. I think we need to learn how to do that all across the country and especially in urban communities. Next. I think that's it. I hope I did it less than my 10 minutes. So thank you, guys.
That was perfect. Thank you so much. So glad you're speaking here today and sharing this with us. Laurie?
Thank you. Thank you very much. I want to thank David, Dr. Whiters for his truth. I want to thank Dr. Monica for her presentation. I want to thank the Recovery Research Institute for the opportunity to have this conversation. I think it's very important. The Black experience, and I don't know if my video is linked to that little icon or not.
Laurie,
but
let me pull up your video because I need to create a new share. But
absolutely. I
Was
want
it-
to share a 3-minute video with everybody. And it says a lot of what's already been expressed by both presenters, but I'm a visual person. I just want you to take this in for about 3 minutes.
In 1986, when I was coming of age, Ronald Reagan doubled down on the war on drugs that had been started by Richard Nixon in 1971. Drugs were bad, fried your brain, and drug dealers were monsters. The sole reason neighborhoods and major cities were failing. No one wanted to talk about Reaganomics and the ending of social safety nets, the defunding of schools and the loss of jobs in cities across America. Young men like me who hustled became the sole villain, and drug addicts lacked moral fortitude. In the 1990s, incarceration rates in the US blew up. Today, we imprison more people than any other country in the world. China, Russia, Iran, Cuba. All countries we consider autocratic and repressive. Yeah, more than them. Judges' hands were tied by tough on crime laws, and they were forced to hand out mandatory life sentences for simple possession and low-level drug sales. My home state of New York started this with Rockefeller laws. Then the feds made distinctions between people who sold powder cocaine and crack cocaine, even though they were the same drug. Only difference is how you take it. And even though white people used and sold crack more than black people, somehow it was black people who went to prison. The media ignored actual data to this day. Crack is still talked about as a black problem. The NYPD raided our Brooklyn neighborhoods while Manhattan bankers openly used coke with impunity. The war on drugs exploded the US prison population disproportionately, locking away Black and Latinos. Our prison population grew more than 900%. When the war on drugs began in 1971, our prison population was 200,000. Today it is over 2 million. Long after the crack era ended, we continued our war on drugs. There were more than 1.5 million drug arrests in 2014. More than 80% were for possession only. Almost half were for marijuana. People are finally talking about treating addiction to harder drugs as a health crisis, but there's no compassionate language about drug dealers. Unless, of course, we're talking about places like Colorado, whose state economy got a huge boost by the above-ground marijuana industry. A few states south in Louisiana, they're still handing out mandatory sentences for people who sell weed. Despite a booming and celebrated 50 billion legal marijuana industry, most states still disproportionately hand out mandatory sentences to Black and Latinos with drug cases. If you're entrepreneurial and live in one of the many states that are passing legalized laws, you may still face barriers participating in the above-ground economy. Venture capitalists migrate to these states to open multi-billion-dollar operations, but former felons can't open a dispensary. Lots of times those felonies were drug charges, caught by poor people who sold drugs for a living, but are now prohibited from participating in one of the fastest growing economies. Got it? In states like New York, where holding marijuana is no longer grounds for arrest, police issue possession citations in Black and Latino neighborhoods at a far higher rate than other neighborhoods. Kids in Crown Heights are constantly stopped and ticketed for trees. Kids at dorms in Columbia, where rates of marijuana use are equal to or worse than those in the hood, are never targeted or ticketed. Rates of drug use are as high as they were when Nixon declared this so-called war in 1971. 45 years later, it's time to rethink our policies and laws. The war on drugs is an epic fail.
Thank you, Hazel. Thank you, Hazel. So that'll give you a perspective on the reality that we have been dealing with for a long time. And that's just the history. They just marked the 50th year of the war on drugs, which was a miserable failure. And these are the experiences of Black and brown people. Next slide, please. So the question posed is, how has racism impacted my recovery and our center's ability to support recovery? I'll share some of my personal experiences very quickly, but I am my community. I am a representative of, and I mirror a lot of what happens to the recovery community. So just to let you know, I am a woman in long-term recovery, and I've been on this journey for a little over 30 years continuously without any breaks. When I went to treatment in 1991, I went to a nice treatment facility. I was one of the fortunate Black people to get into treatment, to access treatment. And I was told immediately, do you know that you're the least likely to succeed as an African-American woman? Well, what did I know about data, statistics, any of that? But what I did know is that something rose up in me, and having a rebellious nature, I said, well, it's not going to be me. I'm not going to be one of those statistics. But that was my greeting to treatment. And then fast forward, 20 years, my husband and I went to San Fran to study the Delancey Street model. And so we stayed in the Embarcadero, which if you ever get a chance to check out Delancey Street, it's a beautiful model. Worst of the worst doing the greatest work. Anyway, right next to our hotel was a meeting place. We belong to a global society for support of recovery. We went to it, walked in, we're the only people of color. We're quickly greeted at the door by one of the gentlemen there who says, can I help you? And I said, I'm here for the meeting. He goes, well, are you sure you're in the right place? Are you sure you don't want Fillmore Street? And I said, Fillmore, what's that? He said, Fillmore Street's where the people who look like you are. Of course, being the person that I am, I pushed right past him, not physically, but I went past him and I took my seat. I earned my seat and I stayed. And I got the support that I came to get. However, that was a discriminatory and racist act on the part of a group that I thought we were all on a level playing field. Let's advance another 10 years, another decade. Worked in a rural treatment facility. I was in a supervisory role. And I had a couple of staff come to me and talk about the human resource director was calling the people of color there by the N-word, by slave names. I filed a formal complaint about it. Nothing was done. I resigned. These are the things that have been a part of my experience in what I believed should have been a level playing field. It should have been a place where we have things in common. My experiences are shared with so many and filled with so many instances of stigma, one level that we all have in common as people in recovery, but then there's another layer called discrimination. The difference is you can prosecute discrimination, you can't prosecute stigma. People of color live with both. And it can be layered even further and deeper than this. Next slide, please. Okay, so what's our stance at our Recovery Community Center regarding harm reduction? At Lost Dreams Awakening Recovery Community Organization, we believe that keeping people alive is first and foremost. It's critical to any recovery goal. First of all, the dead don't walk in. They have to be alive to be able to even walk through our doors. This is something that's been clearly stated by the recovery community. It's not anything that I came up with while I'm a part of that community. This is what is most important to those in or seeking recovery from substance use disorder. Your institute did the research and also supported that in your findings. At Lost Dreams Awakening, we celebrate any goal that an individual identifies as improving their quality of life, life being the key word. That says you're breathing, you have life, you're vim and vigor. Next. Okay, what do we do in terms of actively being engaged in anti-racism activities? Well, I'll say before I say anything else, our membership and our participation in AFRO. And, and I really thank Dr. Whiters for his insight, his vision into having this organization and seeing the need and birthing that and nursing that. We're fully committed to anti-racism activities, education, and advocacy. We are intentional in our approach to be diverse, equitable, and inclusive. And I'm not just whistling Dixie here. I'm not just using buzzwords, DEI, diversity, equity, and inclusion. I'm talking about in word and in deed. LDA, we belong to AFRO, to the African American Federation of Recovery Organizations. We believe in what they're doing, and we support them. There's some brilliant minds at the table at AFRO. We also participate in a group called Black Faces, Black Voices, and a host of other DEI initiatives. We believe in the both and approach. We believe that it's going to take the collective whole to address this huge and complex issue. And it is, it's huge, it's complex. This has been brewing for over 500 years. This just hasn't happened. It's going to take concerted effort by the collective whole. We're engaged in anti-racism advocacy efforts. Here's a critical piece. We're trying to get the word out about the rising African-American overdose death rates, coupled with the fact that 90%, it's actually 91.5 when you add any mental illness. That's the SAMHSA data. I put the link there for people to go and verify this. Don't believe it because Laurie said it. Check it out for yourself. But we get no treatment anywhere. Inpatient, outpatient, PCP, emergency rooms, prisons, jails. We get no treatment. I have advocated for anybody who has been in need in the recovery arena. Whenever it first hit, when the opioid epidemic first hit rural communities, I had buses going to Washington, D.C. to advocate for money, the CARA funding and all that. Talking to the, making films and addressing the Black Caucus because they were mad. They were upset that when it was crack, people were put in prison, and when it became opioids, they wanted to treat it. So they had an issue with this. And so it ended up being a bipartisan vote to give the money to this efforts, but yet the very people who did the advocacy, boots on the ground work, were left out, were completely left out. And so that's an issue. Why isn't the media talking about this? This isn't new. We've been dying. Just in Pittsburgh, August 31st, 2021. The Pittsburgh mayor put out an executive order that overdose death rates among African-American males was up 200%. We would never stand for that in any other population. 200% increase among African-American males, and perhaps that's the reason why the silence. Perhaps that's why, but I'm appalled. I'm appalled that the media is not screaming about this, that the communities of faith aren't screaming about this, that we aren't on the mall in DC over these numbers. And like David said, do we matter? Next slide. So what would be my ask to make things better going forward? Woo, that's a big one. That's a big one, but I'm glad you asked. Please keep this conversation going. Please keep this conversation going. And let's work on some timely local data that it's critically important to creating community tailored strategies. Listen, we know what works. It's been applied to a whole group of people. It just hasn't been applied to Black folks, okay? We know Heather McGee does a magnificent job in her book, The Sum of Us, talking about the approaches that have been applied to the dominant culture have brought down numbers and have been effective in their strategies. All you have to do is adapt those same things to people and communities of color. We know what to do. When people say, what do we do? I don't know what we can do. I don't believe that. I think we know exactly what to do, but we just need to apply it to this particular population, African American, Black and brown communities, and we could be turning all those numbers around. We need implementation work that helps bring effective interventions into the community. A lot of things need to be adapted. Know how to deal with the community that is the most disenfranchised. We are only as strong as our weakest folks of society. That's our strength. And I'm just amazed, it baffles me how that in the United States of America, that we could be silent around this, that we could be okay with this, that we have been lulled to sleep somehow with generations of indoctrination around the color of somebody's skin. Race is a myth anyway. It's not real, okay? It's a construct that was designed to buy and sell people. It's not even real. So let me say this, and I'm going to bring this down. I'm very passionate about this. I'm glad that that I have an opportunity to participate in this work during my lifetime. I am the great, great, great granddaughter of freed slaves. My maternal and paternal grandparents came from Culpeper, Virginia, slaves, freed slaves. So this is personal for me. Many well-intended people ask me, Laurie, when can we stop talking about this? I'm tired of talking about this. And I get you, I hear you. And I say, we can stop talking about this when Black people, my people, stop living it. It's one thing to talk about it, try living it. I don't want to live this. My people don't want to live this, yet alone talk about it, but we'll stop talking about it when Black folks don't have to live it. So it is my humble privilege to be able to have this opportunity to share these things, to communicate these things, especially with my white peers, especially because we need you to get this information to the people who are going to do something about it. We have collective trauma and we need collective healing. Thank you so much.
Thank you so much, Laurie, and it's our privilege to have you here with us today, and David and Monica. It's been a real privilege. We only have a few minutes left, and I understand if people have to go, but I would like to open the floor to anyone who would like to comment or ask a question.
We also have a post-seminar poll. Should I?
Yeah, do that right now while people are thinking about speaking up.
So this is the same poll as last time, but we're just seeing if your feelings have changed about these statements.
I have a question, if I may.
Of course, please.
As an educator, I'm always looking for opportunities to provide access to these materials that we've been privileged to hear about today. So, and I've popped up on Dr. Whiter's website and already trying to find things. And it'd be great if we could curate some information, for college classes, so we could design courses around this material, because it'd just be a great opportunity to do the best that we can with your assistance.
That'd be wonderful. And if you can help facilitate and connect, I would absolutely doing that. So let's talk, Bo, and I'll follow up with Laurie and David and see what we can do. Vindia, I see your hand was up for a while.
Yes, hello, David and all the other presenters. David, it's good to see you. It's been some years. Thank you for your honesty and your forthrightness about this issue. I'm lucky to work in a organization that we are working on, not just talking about it, but being about it. But you know what I often say and I get frustrated about is that as a Black woman, I shouldn't be the one, like I have to live this. And it's exhausting to live this. And people who are in positions of privilege and power need to stand up. When you have the opportunity to go speak somewhere, you need to bring this up. I have a boss who every time, and she's a white woman, every time she goes somewhere, she brings these things up. That video that you showed, Laurie, she brings this up because it's important and she understands her privilege. People need to use their privilege. And I can't say it enough. As a Black woman, I am exhausted living it. I'm not here to educate people. You need to educate yourselves, and then you need to also stand up.
Well said, absolutely. Thank you, Vindia. Lawrence, you also had your hand up.
Hello, everybody. I just want to say this has just been a phenomenal presentation. Actually, it's been a phenomenal awakening. Thank you, David. Thank you, Laurie, and all of our presenters for such a powerful message. And I want to reiterate that because in this process, I also don't want us to forget about our LGBT persons of color, because we experience the same kinds of disparities, oftentimes even more so than the heterosexual community. So I just want to reiterate that we are all in this battle together, and we cannot leave out any people within our community as we move forward. So thank you so much again for the presentation.
Thank you. Thank you so much. I absolutely agree.
And I'm just sharing the poll results now because I think we want to reveal the true or false of each answer. So it should be up on everyone's screens now.
And all of those statements were in fact true, and we can send you guys the resources for those. Michael, I also see your hand up.
Yes, Michael, ask you a person in long-term recovery, live from Myrtle Beach, South Carolina. My friend there, Dr. Whiters and Laurie Johnson Wade, thank you so much for that strong conviction that you have in wanting to make change in the Black community. I just want to hope that SAMHSA's new Office of Recovery will work alongside the Biden administration to realize the impact that they too can make. Those two agencies, the president and SAMHSA can make, in bringing a true essence of recovery to the Black communities that are still impoverished, underprivileged, marginalized. And I know that because of what we just heard, there should be some people on this call that are willing to take the step, like it was said, and step out on faith and work in this community to help this happen. Thanks for this totally awesome presentation, you guys. And I hope that this does not go unheard to those that heard it. Thank you.
Thanks, Michael.
Love you, Mike.
We unfortunately, I hate to bring this proceedings to an end here at 1 o'clock, but I know some people have to leave. I know myself and others will stick around. If you want to stick around and have a conversation, please do. But let's give a hand to our fantastic panel, to Laurie, to Monica, to David. Thank you so much for a great, very thought-provoking set of presentations. And thank you for all the great comments and questions, and for coming today. Don't forget, November the 5th, we'll be talking about harm reduction in more detail. So please come back then. Thank you. Have a great weekend. And again, stick around if you want to continue the conversation.
Thank you, Dr. Kelly.
Thank you.
Thanks, John. Thanks, Bettina. Thanks, Hazel. Thanks, everyone. Good job,
Thank you
guys.
all.
Thank you.
Thanks, Bettina. Dr. Hopner, thank you.
Bettina. This has been amazing. I love this. You guys are so powerful and so motivating, and so speaking to our hearts for moving forward. Thank you.
Thank you. Thanks, Hazel, for all your hard work.
No problem. Thank you for presenting.
Yes.
I'm always so grateful for Hazel to just steer it all. We just have to
Oh,
get to lean back and enjoy, and she figures out all the technology so we can do this.
Yeah, can't do without her.
Indeed.
Any other
I want to
thoughts or
say that,
questions? Yeah,
I
Thomasina.
want to say as a white privileged person, I really appreciated the very concrete and practical way that I could contribute by using my position of privilege to get the word out, to speak up at all times. I think that was so helpful because sometimes I feel so helpless in the face of systemic racism. I mean, I'm very aware of it, but what can I personally do? Well, this gives me something concrete and a way of thinking about it that is very, very useful. So I really appreciate that. Thank you.
Thank you, Thomasina.
Thank you.
Thank you for sharing that. George, I see your hand up.
So, yeah, the United States locks up more of its citizens than any other country on the planet. And the state I live in is the worst in terms of the number of citizens it locks up. So we lead the planet in Georgia. My question really has to do with the message that we can carry to our legislators around the idea of enhancing community safety, principally by shifting funds away from correctional systems to recovery systems. And I know we got a new Office of Recovery, and that's wonderful. I have been booed and hissed and essentially run out of working in the Georgia criminal justice system because there are so many economic implications if we reduce those correctional budgets. So I'd just like to hear, with the brilliance that's in the room, what your ideas are about the new message for moving forward to create a more safe and healthy community.
Can I try to address that with emphasis on try?
Sure.
Hey, George. Hey, it's good to see you, man. Thanks for being here. Just got a great deal of respect for you. You're one of my recovery heroes.
Yes.
One day I was in the library. I was a student in Michigan, and I was working on a project, and I came across this book on the history of the correction system in Michigan. Michigan has two parts. There's an upper peninsula and lower peninsula. It's completely separated by water. For those of you who know that, there was a group of senators or congresspeople, whatever they were, elected officials in the upper part of the state, the upper peninsula, who were looking for ways to create jobs for their community. In the lower peninsula, we had all these General Motors plants, Ford plants, and Chrysler plants. So there's plenty of work for people in the lower peninsula. They created this prison. They built a prison. It was at the northern part of the northern part of the state in the upper peninsula. And then they needed some people to fill it up. And so they started recruiting judges from Southeast Michigan. There's one major city in Southeast Michigan. It's called Detroit. At that time, it had 2.1 million residents, most of whom were Black people. They started giving them these long sentences. And then they would send them to this prison up in the UP, which was a 6-hour drive. And so guess what else happened? The little motels on the lower side of the peninsula, right before you cross, because you can't cross at night because the wind blows, and it'll blow you off the bridge. It's called the Mackinac Bridge. So they had to stay on this side of the peninsula, and they would stay in these little bitty motels. They would double the prices because they knew these people were coming from southeastern Michigan to go visit their loved ones. And then when they got on the other side to visit them, they would double the prices on the hotel because they would have to spend the night because you couldn't drive back at nighttime. You would have to wait until the sun came up. And then they started this thing where they started charging them a whole, you should call from prison to talk to your loved ones at a reasonable rate. Then they came up with this bright idea to start doubling the rate. And so some of these people were losing their homes because of their phone bills that they were getting as a result of talking to their family members. So I tell you this story to tell you this. I'm not for sure there's much of anything we can do. One of the strongest unions in the state of Michigan, and Michigan is a state that's got a bunch of unions, is the union that protects